Welcome to our session, Small Renal Masses, an Overview. I'm Brian Schuck, Associate Professor of Urology at UCLA, the Director of the Kidney Cancer Program. Thank you for the KCA for inviting me to give this small renal mass overview. Got a lot to cover. A lot has changed in the past couple decades. Prior to 1980, we had our kidney tumors often would be found sometimes through workup by the internist for kind of vague symptoms. Patients could have a flank pain, a mass, and some blood in the urine, but there were really subtle signs such as maybe fevers or cough or abnormal labs. But things have changed now. In the past couple of years, we have a lot of accidental or incidental diagnoses of smaller and smaller renal masses that are found when patients get imaged, where we call incidentally, or when they're asymptomatic, really for a scan that's unrelated to why they were diagnosed. We've seen patients come in for chest pain, had a patient with a spider bite, they get imaged, and lo and behold, they have a kidney tumor. The kidney is very well protected, and most of our small renal masses will not cause any pain. These are two patients I operated on the same day. Okay, one was a 25 centimeter tumor and the other is a 1.5 centimeter tumor. You know, on the left, we have the giant tumor, which is how we used to see many of our kidney tumors in the 50s, 60s, 70s. We occasionally see this, but now more and more we see tumors on the right, which are small incidental findings. Well, kidney cancer has dramatically increased. We're about 2 or 3 times higher in the number of cases per 100,000 people. And these imaging studies are now more widely available in the ER. Every ER has an MRI, multiple CT scanners, and practitioners often order imaging studies necessary, but often many are unnecessary due to kind of we call CYA medicine. And this sometimes leads to findings of things which may have never needed to be found, like a small renal mass in some patients. We do know that data shows that up to 43% of Medicare patients over a 5-year period will have imaging of their chest or abdomen with a CT scan. So we're finding more of these small tumors. And lo and behold, most of these are small tumors, not the giant tumors destined to become symptomatic. Many of these are small 2 to 4 centimeter renal masses. And this basically, again, has kind of tripled or quadrupled over the past 20 years. Because we're finding things earlier, the stage of the tumors, stage 1, has increased, and things like stage 4 have decreased. And that's really from up to 2004. In the past 15 years, it's largely remained stable, but about 70% of our kidney tumors are really stage 1 now. You have a spot on your kidney that's diagnosed. The question everyone asks is, what's the best treatment? Well, hold on, cool your jets. Does a lesion equal a mass? Sometimes. Does a mass equal a tumor? You know, sometimes. But does a tumor equal cancer? Sometimes. Just because you have a spot on your kidney, don't jump to saying this is cancer, what's the best treatment? So patients come to me, they say I have a spot on my kidney. Well, in reality, 1 in 10 patients have an abnormal spot or a lesion. And actually 50% of patients over the age of 50 will have a lesion on their kidney, okay, or a spot. The majority of these are going to be cysts. How can we tell what is concerning? Well, we get imaging, and imaging of the kidney generally, you know, more commonly is an ultrasound, a CT scan, an MRI. There are other modalities which have specific purposes, but these 3 are the mainstay of therapy. When we get imaging, we try to look at things like location, how many lesions there are, what's the density, are there calcifications, etc. And obviously things are different, and not all lesions or spots are created the same. The tumor on the left, a 2 centimeter lesion, clearly is less concerning than something like on the right, which is 30 centimeters. Now, how do we know if this spot is a tumor? Okay, well, the mainstay or the bulk of this type of work is done with a CT or an MRI, but now with ultrasounds. Contrast is really our hero here when we want to see whether a spot or lesion is a tumor. Basically, what we do is we put an IV in a patient. We give a very heavy, dense metal or contrast, either iodine or gadolinium, and it goes throughout the body. You do the scan. If the kidney lights up, it's a vascular organ, and this lesion does not light up, it's a cyst. So no contrast taken up, clearly a cyst. If contrast gets into the kidney, the tumor becomes bright, so does the normal kidney. This is a vascularized structure. Clearly, this is a tumor. So that's how we know that something may be a cyst. And what a cyst is basically a bag of fluid for the most part. And the kidney forms these structures. Sometimes they just contain a fluid. A cyst, again, it can also be a little bit more complicated. Sometimes this bag of waters contains, other types of structures, such as mural nodules, or potentially more complicated septa, or we call dividers. And when we see these lesions, most of them are not that concerning. But we had a radiologist named Dr. Bosniak help us risk stratify, and there's clearly a continuum between a bag of water cyst and a solid structure. And the radiology community has been trying to lead the horse to water, lead the urologist to help us from removing these benign or unnecessarily treated lesions. So they have a classification system where the more complex the lesion is, it gets a higher Bosniak score. And basically, our radiologists try to risk stratify these lesions into those that are more concerning and those that are less concerning. The ones that are less concerning, we don't need to follow. The more concerning complex structures, we need to do more intervention, surveillance, or potentially treatment. Now, if you have a solid tumor, okay, we call an enhancing renal mass a tumor, okay? But the most important thing to understand here is a tumor does not equal cancer, okay? And some tumors are benign. And a cancer does not mean an aggressive or dangerous cancer. There is a wide variety of tumors that could be ranging from very indolent, which wouldn't hurt you for a 10, 20-year period, or ones that are going to want to fly out of the kidney very quickly. But for tumors less than 4 centimeters, the majority are either benign or low risk or indolent, meaning they're likely very slow growing. Now, this varies by size. Clearly, a 20-centimeter tumor is more concerning than a 2-centimeter tumor. The smaller a tumor is, the more likely that tumor is likely to be benign. So up to 40 to 50% of tumors less than 1 centimeter are going to be benign. If you're a woman, you're more likely that this tumor could be benign. So for tumors that are less than 3 centimeters, about 30% in women are going to be benign. For men, it might be about half of that. Now you can put all this together: size, location, smoking, gender, age, and you can put out really what is the likelihood that a mass will be cancer. So again, it may range from 50% to 90%, depending on many of these characteristics. The question I always pose to patients, when we understand it is a mass, we understand that it's suspicious for a cancer, should I get more information? There is a fork in the road at this point. We know it's a small renal tumor. Can we just go and recommend management? Okay, we could. Or can we get you more information? And in 2020, we have lots of tools, such as fancy imaging studies. We can do biopsies to get more information to better risk stratify the tumor. But we can never be 100% certain. We might be 95% certain about the biology of the tumor. So some patients may just elect to go right for management, okay? And the management could include a partial nephrectomy, a radical nephrectomy, ablation, or surveillance. We'll get into that later in the talk. But one thing to get more information is a biopsy. A biopsy is a small pinch of the tumor, and it is used for a microscopic evaluation. We use minor anesthesia. It is something where you feel a little bit sore, but it's not too painful, and the next day or two, you recover pretty quickly. You just feel a little bit of mild tenderness on the side. And the needle goes right into the tumor, and we get a little sample to look under the microscope. The major complications are very rare. We use image guidance to find the tumor, and we sample it. The most common complication is bleeding, okay? But only 1.5% of those cases with bleeding ever would require a hospitalization. Okay, the risk of seeding or spreading tumor is not really a concern. For some reason, we've had this misconception that a biopsy is somehow dangerous. We biopsy almost every solid tumor in all of oncology, whether it's lung, whether it's prostate, whether it's breast. We don't offer treatment for kidney tumors. We've classically omitted this because we thought it has not always reliably changed management. What about imaging? We have fancy imaging tools which are available to help us. We can look at what's called the enhancement patterns. And as you see here, a tumor without contrast may look dark. It may look very bright. And then over time, it becomes less bright and less bright. So we can actually characterize the enhancement over time and predict the biology of the tumor, whether it is a clear cell kidney cancer, a papillary kidney cancer, what type. Okay, we have a new tool called sestamibi imaging, which may be useful for detecting some types of benign tumors. We're using this at our center, but we're doing it under a research protocol to see if it changes management. Basically how it works, some benign tumors, they may have a lot of mitochondria. For that patient with a 70% risk that tumor is cancer, if the test was done and it was no uptake, that would have maybe a 90% chance of cancer. If there was a lot of uptake, it might be 50% chance of cancer. We're not sure this reliably has the ability to change management routinely, but we're looking at that at a study at UCLA. So again, you're at the fork of the road. Should you obtain more information? I try to counsel all our patients, you don't do a test unless it's going to influence your decision. If I could reassure a patient with 90% certainty it's benign, if the patient is not willing to accept that to change their decision-making, don't do the test. If I stick a needle in and I biopsy and I can confirm cancer, if that's not going to change the management, don't do the test. So we try to offer more information when we feel like it's going to be helpful for an individual patient to decide management. So what are our options in 2020 for management? Well, we have things like surveillance, close observation, radical nephrectomy, removing the whole kidney, a partial nephrectomy, removing the lump, or ablation, just sticking a needle in and freezing. We're going to talk most of this on early stage, stage 1. Again, that's the title of the talk, small renal mass overview. The small renal masses in general are stage 1 disease. Now, radical nephrectomy, where we'd go in and we would remove the kidney, the adrenal, the ureter, the vessels together, was the historic mainstay of therapy. Your left kidney looks bad, your right kidney looks good. Well, let's just take out the whole organ. We basically don't disrupt any of the fat around the kidney. It may minimize the risk of local recurrence in that area, meaning there's no more kidney remnant to leave behind any disease. We're now doing less of this. The adrenal can be spared as well. We've become using this modality a little less frequently. We could do this approach through many different ways: a large cut on the flank, a incision below the ribs, incision up and down. But more and more, we're doing probably 90% of these operations for small tumors with tiny incisions, laparoscopically or robotically. Okay, well, we do know the kidney is important, and removal can lower kidney function, and loss can maybe predispose some patients to chronic kidney disease. So we only offer this radical nephrectomy nowadays for small tumors when we're concerned about increased oncologic risk, maybe a high extent of complications based on the tumor and the patient, and the other kidney looks normal with good function. Nowadays, I only personally remove the whole kidney if the kidney is not working. Patients on dialysis, why do we need to spare that kidney? Maybe they have had a transplant already. But nowadays, we don't do this very often for small tumors. Most of the time when we do it a minimally invasive approach. Whether we use laparoscopic equipment or we take those laparoscopic equipment and we attach them to the Da Vinci robot, it's based on the surgeon preference. Next, the bulk of our operations now that we do for small tumors are called partial nephrectomies. This is similar to a breast lumpectomy, where we go in and we remove the mass. We used to do this only when a patient had really an imperative indication to spare the kidney's function in patients who had, let's say, one kidney, multiple tumors, poor kidney function. But nowadays, we are using this routinely because the outcomes are similar to taking the kidney out completely. So if the cancer outcome's generally the same in terms of the risk of progression outside the kidney, we generally try to offer this. There may be additional benefits in some patients where you would want to preserve their kidney function, younger individuals, those with higher risk of developing chronic kidney disease. And there's potentially some improved quality of life issues. We have seen this in some large data sets. We tried to do a trial in this setting. It was hard to convince patients to do a randomized trial, so it didn't really accrue well. But the field generally likes to preserve kidney function with this approach. There are additional risks. If you cut into the kidney can bleed. The kidney can leak urine, but they're generally very acceptable. We are now doing this operation with closer and closer margins to the tumor. We used to take wide excisions of 1 centimeter. That destroys large chunks of kidney. Now we get right up to the tumor and we take really a mini margin. But classically, the rate of local recurrences were low. But nowadays, with more and more aggressive tumors being removed, we are seeing that maybe a little bit higher rates of local recurrences. So you got to be careful about pushing the envelope too far. Now, partial nephrectomies can be done with large cuts, okay? And we do this for tumors that sometimes are a little bit more challenging or patient body habitus. But now we can do a lot of them with the laparoscopic equipment, or again, we can attach these to the Da Vinci robot. So the robot has similar outcomes versus like laparoscopic equipment. I tell patients it's really easy to use chopstick to pick up sushi, but it's really hard for me to sew a button on someone's shirt with chopsticks, okay? The laparoscopic approaches, you can articulate your instruments, and it's basically an enabling technology, and most people do this operation now with the Da Vinci robot. Now, the next approach that we are using more frequently is called thermal ablation, where you can focally destroy a tumor with extreme temperatures, such as freezing cryo, or heating with radiofrequency or microwaves. Here on the left, you have a Levine needle where you have antennas which help transmit the heat, or on the right, you have cryoprobes where you use argon gas to freeze. The tumor is left in place, it's not removed, similar to radiation where the tumor just gets killed, okay? The definition of success thus it differs. Removing or excising a tumor is how surgery works. But for an ablation, the tumor is there. We want to make sure that there's no growth, no enhancement with the contrast. We're happy. If it increases in size, we're concerned. But increased imaging with ablation is standard. You do a lot more imaging for follow-up. The laparoscopic approach used to be done often. We're doing a lot of these just more percutaneously through the skin. And they have similar outcomes with a little bit less issues with morbidity. Now, this approach does have lower success than with surgery. Again, the definition of success are different, but it's very effective. We're talking about maybe an 80 to 90% rate of success for the right selected patients. Larger tumors are less successful because you need to completely cover those tumors. But 50% of those failures that the patients on imaging, they still have a lesion present, or the lesion's growing, or it's enhancing, they could be salvaged with another treatment, okay? The small percentage of patients where it's unsuccessful may need a surgery to salvage that situation, which could be challenging. The one thing I must say is you need to know what you kill. So either biopsy before or biopsy at the same time, so you try to get a better understanding what type of tumor was killed. Now, what about doing nothing? Okay, we know, again, this graph I put back up, that 90% of these tumors are either benign or more indolent. We do know that patients that sometimes used to die of other causes on autopsy were found to have small tumors. And a lot of those tumors were not destined to cause any harm. They were incidentally found. So the epidemiologic data suggests that a lot of tumors are completely overtreated, okay? The number of patients dying each year has not really changed, yet we're operating on 4 times more patients today than ever before. So the question is, can we watch many of these small tumors? We do know that patients with kidney tumors are generally, they're not 21-year-old young, college students. They're 64 median age, some morbidities such as hypertension, obesity in a lot of patients, and we have plenty of patients in their 70s or 80s. So if you put in someone here, this would be an African-American male with kidney, age 70, with a 2-centimeter renal mass, with hypertension, maybe some reflux, prior MI. The risk of this patient dying in the next 5 years might be 30%. The risk that this kidney cancer would kill that individual is 1.8%. So everything in life is a calculated risk, okay? You fly is a calculated risk. Going outside in a lightning storm is a calculated risk. Maybe not treating a tumor, or treating a tumor knowing someone has morbidity and is at risk for anesthetic complications is a risk. So again, you need to understand that risk and decide. In patients who are too sick to have treatment, this nice study from our friends in Toronto and looked at most of these tumors grow slowly. There is a rate of progression towards needing treatment or having symptoms, but the rate of distant spread is very low, 1%. Okay, and if you follow tumors, you have sometimes the tumors which in green will just stay flat and not change over time. Other ones will grow slowly, and there are other ones that will declare themselves early. So this one over here, in the first 6 months or year, you may decide, to go in and offer patient treatment, and you have a very high chance of success of not having a tumor disseminate. Left alone or untreated, this tumor would be concerning for development of distant disease. So when you're looking at treatment options in 2020, okay, you have obviously lots of approaches. Many patients go online, okay? And I would tell you that there are some very good places to look, like the Kidney Cancer Association. But, there are things just like there's, terms fake news, conspiracy theories. I would tell you that a lot of support groups, may have patients who may not be giving the right information. We've had patients with metastatic disease discussing treatment options for patients with a 1-centimeter tumor. I would tell you that you just need to be cautious. There are, support groups that are outstanding. There are, websites, cancer.gov, the Kidney Cancer Association. Just have to be careful where the information is coming from. So obviously, it's important to have what's called shared decision making. There are multiple options available. Most options for patients with kidney tumors will be curative. Remember that all treatments have potential short or long-term side effects. So not one size fits all for every patient. So you really need to have a doctor who is willing to individualize, okay? So if you have someone, the saying is, if all you have is a hammer, everything looks like a nail. Okay, I personally will say, we do surgery here. I do open surgery, robotic surgery, laparoscopic surgery, small incisions, big incisions. I do my own ablations. I would say that, you need to go to someone who is flexible and doesn't say, I only do one thing. Okay, and if they only do one thing, they need to make sure that there's people on their team that are willing to discuss all the different treatment options, because again, every option is useful for the right patient. Some options may not be useful. Doing an ablation for an 8-millimeter lesion in someone who's 95 may not be the right option. It may be the right option for another patient, okay? Now, clearly, tumor size, this 2-centimeter tumor is very different than this 25-centimeter tumor, which is the size of a child, okay? So size influences decision-making. What about patient health? Well, clearly you see Usain Bolt here, you may want to offer him a partial nephrectomy. And this woman, who might be 85 in a nursing home, you may say, well, that 2-centimeter mass, maybe you would potentially watch it. Okay, but there are plenty of older patients over here. This gentleman, what about him? He may come to you and, say, oh, you're 85, we're not going to offer you treatment. In reality, there are plenty of patients where age is just a number. We have a patient last week who's 31 and very unhealthy. I'm actually going to watch that small tumor. Okay, so we need to put everything together and individualize care plans for every patient. Okay, now in conclusion, I would say, that the presentation of kidney tumors dramatically different. Our kidney cancer in 2020 is not the same as in 1980. Okay, a renal lesion, mass, or tumor, these terms are challenging to understand, but they do not equal cancer. And a renal cancer does not mean the tumor is dangerous. A lot of these left untreated would not cause any problems over a 5 or 10-year period, okay? But some do, and some are aggressive. More information is available if it will change management. We have imaging studies, we have biopsies, we have protocols here, with genetic sequencing. I would say that you would only offer a test if you think that information is going to change management. And that fork in the road is important for the doctor and patient to understand that fork and which path to go. Again, you can get more information and then go to the other side of the street to get discussion of treatment, or you can move forward right for treatment discussion. Management is evolving. We're doing a lot more organ preservation. We're doing a lot more minimally invasive surgery now. Ablation is a useful modality, but we do know there are known limitations. We need the right patient population. Small tumors largely would be a better success. Overtreatment remains a problem. On the population level, yes. On the individual level, it's hard to know if you're overtreating some patients. We do not have the best reliable markers to know which 70-year-old individual with a 2-centimeter mass that tumor would cause harm in a 10-year period versus which are going to remain, unchanged in size if observed. But overall, we do know that a lot of patients were not destined to cause harm, and we have to try to understand who those tumors are. So active surveillance is an option for many patients that wish to safely avoid treatment, but it can't be done without close observation. We covered a lot of information. Patients have questions, want to come see us at UCLA or elsewhere. I would say that it's always useful to get a second opinion from an expert, and the Kidney Cancer Association has, many people available to guide people to the right place. Thank you for your time.